Again, welcome to the Icarus conference. We want to show our case with transradial approach for the common iliac artery stenosis. It was 70-year-old man with the hypertension, asthma, diabetes, coronary artery disease after the CABG operation, and peripheral arterial disease who presents with lifestyle limiting claudication that has progressed to pain at rest. His lower extremity arterial duplex showed the left common iliac artery stenosis up to 80%. His ABI of the left leg was 0.56 without exercise performed. He received some cardiological drugs plus rivaroxaban 2.5 milligrams twice a day. On the CT, we saw the lesions, calcified lesions in common iliac artery. And because it was the common iliac artery, we decided to do the procedure from the radial approach. We decided to put the new generation cobalt chromium balloon expandable Denetic 35 stent. There are stents from 5 to 10 millimeters diameters and the lens from 18 to 78 millimeters. What is interesting and why we decided to put this stent is that it comes with the shaft up to the 170 centimeters, so it's easy to obtain the iliac artery from the radial axis. We puncture the left radial artery. We put the radial short sheath. Then we cross the aortic arch using the soft terumo guide wire. Then we change to the stiff guide wire supracore. We change the sheets. We use the 90 centimeters hook sheet. We cross the lesion. Again, we check the lesion and we made measurements. We put the stent without any problem. To cross the lesion was not a problem. And then the final angiogram showed the good results and good position of the stent. Of course, and sometimes it could be a problem if the lesion will be longer and stiffer, but in this case, it was not a problem at all. Of course, there are two possibilities to puncture the radial artery, proximal and distal. Distal is snuff box. It's, from my opinion, is a little bit more difficult. So we always try to puncture the proximal side of the artery. We always use the ultrasound investigation. It makes the puncture much more easy. We are able to measure the artery even using the color Doppler. And if the artery is too small, we are going to the femoral artery. We use lidocaine to anesthetize the puncture. There are many on the market. There are many sheets which are dedicated to the radial artery. We puncture the artery using this special sheets. There are sometimes the puncture challenges to unable to visualize the needle, to failure to puncture because of the small artery. From the beginning, we use 18-inch guide wire, and we try to put the guide wire under the fluoroscopy. It prevents the damage of the radial artery, because sometimes it's difficult if the especially if in situation when the radial artery is small. So under the scopy, it's much more easy to put the guide wire. Because we need to change the sheets, we always do the small cut. We we always use vasodilatators because in many cases there is a spasm of radial artery. Some of the colleagues, they're waiting for the spasm. We think that from the beginning is better. In all the cases, we use heparin 5,000 units to all the cases. Of course, there are some pros and cons to transradial access. Pros is the decrease the vascular and bleeding complication, early ambulation, and patient comfort. But of course, there is no bailout options requiring cover stents for aortoiliac intervention, in little bit increased radiation, not too many devices, and some technical challenges. But of course, the ambulation of the patient is really very easy, and the patient could be discharged in the same day. Of course, on the market, so far there are not too many devices for the radial access operations going below the femoral artery. But I think the future will be much better. So, ladies and gentlemen, in our conclusions, we can say that an excellent angiographic result was achieved. Angiography showed full patency of the artery without residual stenosis and no compromise of the internal iliac artery. We did the ultrasound of the radial artery, and the flow is full. The patient was loaded with 300 milligrams clopidogrel and 100 milligrams of acetylsalicylic acid. Follow-up examination after 4 hours on duplex sonography showed normal pulse. The patient was discharged from the hospital without any problems in 24 hours. But of course, after such a access, the patient could be discharged after 12 hours. At 1 week follow-up, the patient reported that had a pain-free walking distance of more than 3,000 meters. So thank you very much for your attention.